All right, everyone, welcome. In this explainer, we're going to tackle acquired foot and toe deformities. And look, this is a super important topic, whether they're aiming for orthopedics or you're heading into primary care. We're going to break down the why behind these conditions, exactly how to evaluate them, and of course, the best ways to manage them. Okay, let's jump right in. Here's our roadmap. We're going to start with the core biomechanical concepts, the real foundation. Then we'll walk through a clinical evaluation, learn to spot the key deformity patterns, talk treatment, and then wrap it all up with the most important take-home messages. So first things first, let's lay down the foundational principles. To really treat these deformities well, you first have to understand the forces and the failures that cause them to begin with. Right, so these deformations don't just pop up out of nowhere. They're almost always driven by some underlying pathology. Think about big systemic inflammatory conditions like rheumatoid arthritis, or major mechanical failures like posterior tibial tendon dysfunction. Heck, even something really focused like osteonecrosis can kick off this whole chain reaction of structural change. Okay, the first massive concept you have to grasp is instability. Just imagine the foot as this perfectly, carefully balanced structure. Now, what happens when a critical part, say the first ray, gets unstable or the tendons just aren't balanced anymore? Well, the whole structure starts to deform. And that idea, that's right at the heart of so many issues we're going to look at. And this follows perfectly into the second key concept, forefoot overload. So if that first ray fails to do its job and bear weight, where does all that force go? It has to go somewhere, right? It gets transferred right over to its neighbors, the lesser metatarsals. This isn't just some theory. It's exactly why your patients come in with pain and calluses right under their second and third metatarsal heads. It's a true cascade of failure. Okay, so let's see how these core concepts actually apply in our clinical workup. With this foundation, we can go into the patient history and the physical exam with a much sharper focus. Our evaluation is pretty much a classic two-step process. We always start with a really thorough history and physical exam to gather all the clues, and then we confirm and actually quantify what we found with some targeted imaging. During the history and exam, you're basically a detective. Where exactly is the pain? Are there callosities that perfectly map to our theory of transfer metatarsalgia? Now, a really key part of the exam is checking for deformity, flexibility. Can you manually correct it? I'm telling you, that single finding is going to dramatically change your treatment plan. And of course, don't forget to test specific tendon function. Now, listen up, because what's really important here is the emphasis on weight-bearing radiographs. I can't stress this enough. A non-weight-bearing film can totally hide how severe a deformity like adult-acquired flatfoot really is. You absolutely have to see how the bones line up under a load to truly get the pathomechanics and plan your intervention. All right, so our evaluation is complete. Now it's time to figure out exactly what we're dealing with. Let's look at the most common deformity patterns you're going to see out there in the clinic. Okay, pay close attention to this table. This is super high yield for exams. Claw, hammer, and mallet toes. They get confused all the time, but they are very distinct. The secret is just to focus on which joints are involved. So if it's only the DIP joint, you've got yourself a mallet toe. If the MTP joint is hyperextended, it's a claw toe. If you can master these patterns, you're going to nail the diagnosis every single time. Hallux valgus, what most people just call a bunion, is the absolute perfect clinical example of our core concepts in action. It is so much more than just a cosmetic issue. It directly represents that first ray instability we were talking about, which then leads to forefoot overload. As that deformity gets worse, the joint gets arthritic and painful. And for those really end-stage cases, an MTP fusion is an incredibly reliable way to get rid of the pain and restore stability. Now, if you have a patient who comes in with pain that's located specifically at the second metatarsal head, you have to have Freiberg-Köhler disease on your differential. This is avascular necrosis, which leads to a collapse of the articular surface. Early on, you can manage it conservatively, but chronic deformity, that's often going to need surgical correction. Adult-acquired flatfoot. This represents a huge structural failure of the foot's medial support. It's a progressive condition, and it's driven by the breakdown of the posterior tibial tendon. This is what leads to that classic flat, pronated foot. Managing this really requires a careful, staged, and often pretty complex approach. So that brings us right to management. Now that we're feeling good about diagnosing these conditions, let's build a logical treatment plan, starting with conservative care and then moving to surgical options when we need to. So, when is surgery the right move? Well, it's pretty straightforward. It's when our conservative treatments just haven't given enough pain relief or functional improvement. If the deformity is rigid and you can't manage it with things like shoe modifications or orthotics, or if there's significant arthritis, then yeah, it's time to start thinking about a surgical solution. And this slide just lays out the whole spectrum of treatment beautifully. For those flexible deformities, we start over on the left side. Better shoes, orthotics, physical therapy. The goal here is to accommodate the deformity and rebalance the forces. But for the rigid, painful, or advanced conditions, we have to move over to the right side. And the choice of procedure, whether it's a simple soft tissue release or a complex triple arthrodesis, is dictated completely by the specific pathology and the stage of the disease. Whew, we have covered a lot of ground. Now, let's just boil it all down to the key take-home messages that you're going to want to have locked in for your exams and, of course, for your clinical rotations. Okay, here's what it all comes down to. If you can remember these 4 principles, you'll be able to navigate almost any acquired foot deformity you come across. Number 1, understand the biomechanics of imbalance and overload. 2, always get weight-bearing x-rays. 3, know the difference between a flexible and a rigid deformity because that is what will guide your treatment. And finally, number 4, always start with the least invasive options first. Master these, and you are going to be well prepared to handle these really challenging cases.